morning. My name is Sarah Diedrich Hasdorf. I'm the Deputy Director of Government Affairs for the Wisconsin Counties Association. I am pleased to have the opportunity to moderate our February webinar series on diversity, equity, and inclusivity. Welcome to week 2, where we will be discussing racism as a public health crisis. As I mentioned last week, discussions surrounding diversity, equity, and inclusivity can be very difficult to participate in and can get uncomfortable at times. Yet it is critical that counties begin to take steps toward meaningful discussions on diversity, equity, and inclusivity throughout the many roles that counties play, whether as an employer or as a provider of critical state and local services. Our 4-part webinar series is designed to introduce DEI to counties and provide you with some tools to get started. This is by no means the only work we will be doing as an association on this issue, but it is our starting point. We all have a lot to learn on DEI, but you should know that this is a safe space in which to ask questions and to learn. Before I turn it over to our presenter for the day, I would just want to mention how Q&A will work this morning. We will be utilizing the chat and the Q&A features of Zoom. Please feel free to input your comments or questions in the Q&A or chat feature throughout the presentation. We will take questions at the end. However, Paula will be monitoring the chat and Q&A during her presentation in the event a critical question does come up. So again, part 2 of our webinar series is entitled Racism as a Public Health Crisis. We have a wonderful presenter today who's going to share her knowledge on this issue with us. Joining us today is Paula Tran Inzeo, and Paula is with the University of Wisconsin Population Health Institute, Mobilizing Action Toward Community Health, or MATCH, and she's the group director. One thing that doesn't appear on her bio, and I'm not going to read her full bio, as I think we have emailed it out multiple times now, but one thing that's not on her bio is her connection to local government. Paula serves on the Board of Health for Madison-Dane County, and she is also the co-president of WALDAB, or the Wisconsin Association of Local Health Departments and Boards. So with that, Paula, thanks for joining us today, and the floor is yours.
Thank you so much for having me today, Sarah. Can you hear me okay?
Yes, we can hear you just fine.
Wonderful. I'm so pleased to start out our week with you all today. We've been doing a lot of work across the state to really partner with local governments. So really pleased that equity, diversity, and inclusion is a theme of your webinar this month, and really thrilled to share some information. At any point, please feel free again to drop into the Q&A in the chat, and for conversation, I'll watch the chat for anything that appears to be a burning question, but I do see some suggestions in there already. So I'm going to go ahead and get started today. My task for the day is to talk with you a little bit about how racism in particular is a public health issue. And that doesn't mean that public health needs to be the way that you lead off. Our intention is not to have health or public health as an agency or a sector dominate the work. And what we have found is that this particular framing helps folks see how racism really cross-cuts across several sectors and has long-term implications for the health of communities. So I'll talk a little bit, I'll frame up a little bit of what that means, and also some opportunities for action. A little bit of background on the Population Health Institute. We are housed within UW-Madison, and our work is statewide. Our vision really centers on equity through supporting community connectedness and building strong communities where we value and support each other. We have 4 major units within our Population Health Institute: the County Health Rankings and Roadmaps, which is a national program; our Evaluation Research Unit, which offers evaluation services at very local levels, down to the neighborhood level, all the way up to national programs and policies; our Health Policy Unit, as well as the unit that I direct, our Mobilizing Action Toward Community Health group. Within our unit, we really focus on how we support changing practice, orienting priorities, and also shifting power to really think about how we are working together to support the root causes of health and equity. And we do this through providing training and technical assistance, supporting engaged research, particularly on social and economic factors that shape health, and also convene conversations to support ongoing statewide alignment around health equity. The initiative that this work lands in, the racism as a public health crisis, really falls within our alignment efforts. And we've been building partnerships to convene conversations for many years now, but in particular in 2017, that's when we started bringing partners together to really talk about not just what health priorities are the most important for our state, but really how can we, regardless of what health priority we're working on across agencies and partnerships, really think about strengthening cross-cutting infrastructure to focus on our shared priorities. So these were the 6 that we generated, and the one you see there as a third dot point makes up our conversation today, to really talk about how racism is indeed a public health crisis. So as I have this conversation with you today, really want to encourage you to think about how these topics show up in your own community. We really want to get to a conversation of how your local context is really shaped by these topics, and how that brings the most meaning for you in your own individual work, as well as the work in your communities. We know that when we have these conversations, that they can feel theoretical and academic, and at the heart of making progress on this work is really looking at our own communities, looking at our local assets, and really asking the question of how this shows up here, and what resources and assets do we have to really address these issues in a way that makes the most sense for our communities. So first, I want to start off with what's in it for me. You know, I come to this work certainly with training and in the field of public health, and also as someone who's been at the university, but it's also really personal. Before I came to this work, I came on a journey, and I want to share that a little bit with you, in part to ground myself around what keeps me honest about this work. We all have a lot of learning and growing to do, and also because it's really our local stories that shape the context in which these issues emerge, as well as, again, our opportunities for change. So, a little bit about my story and why this work is a strong thread throughout my career. Starts with my dad. This is him in the late 70s, and my parents grew up in central Vietnam. And in the late 70s, they were arranged to be married, very traditional marriage where they did not meet each other beforehand. And soon after they were wed, my dad decided he was not going to raise his kids in communist Vietnam. And at the time, you know, this is post-war, and many young people coming of age felt the same way, that they didn't feel like the government was with them, and that was not the context in which they wanted to raise their families. But at the time, the US, while supportive of refugees coming into country, was no longer providing supports for those to get out of the country. Vietnam's government was certainly not supportive of its young workforce leaving. So many folks, after the several initial first waves of getting refugees out, had to escape. So my dad hatched a plan with his cousins to escape country. And my grandpa actually found out about their plan, like most astute parents do, and threatened my parents, said to them, if I catch you escaping, I'm gonna I'm going to take care of you, because that would be much more humane than what you would experience if you were caught by the government. So my grandpa camped outside my parents' bedroom door with a gun, promising to take care of them if they were caught. And my parents, like really good activist-oriented young people, escaped through their window. and made off on a stolen boat. And it's still unclear how long they were at sea. The memories are cloudy and don't come easily to talk about. So they left and they landed in nearby Hong Kong, who at the time was British rule and ally to the US government, as well as those that were fighting in opposition to the Vietnamese government. So they landed in Hong Kong and they got connected to programs, government-based programs to help them get to the US. But they found out that my mom was pregnant and couldn't get to the US right away. So they spent her pregnancy in a refugee camp in Hong Kong. Those of you that work in refugee services and provide care to those that are coming over know we don't like to move pregnant women. So that's where they stayed until they had my oldest brother, Hong, and then got set up to come to the US. Again, those of you that are providing services at the county level know that many of our refugee services are run by VOLEGs, our faith leaders in the country. And that's why Wisconsin, Minnesota, and California were the leading states to bring in Southeast Asian refugees at the time because of our strength in our faith institutions. And that's how I got exposed to Catholicism due to wonderful faith leaders in Green Bay. So we got connected with the church and came to Wisconsin. And that was really our own connection, our only connections to the state. We didn't have family here. My parents certainly had not heard of Wisconsin, had never seen snow, had never heard of the Packers, and had never seen fried cheese. So their experience journeying here and their connection to the state really relied on our public sector and our social service community. And they stayed after many of their friends and family left due to the cold weather. And they stayed because of a rich network of services. My dad knew that the only way for his kids to make it here was to get an education. And even though that was really a challenging journey, that is what we stayed here for, and found out pretty quickly that it was not only the education infrastructure, the public education infrastructure, but it was also our healthcare infrastructure, that all 6 of us were born as Badger Care babies and really relied on the policies, systems, and programs to not just make it through the day, but also to eventually stabilize our family context and also thrive. That while many folks didn't think that we might make it in the state, we did all graduate from high school, all get 4-year degrees through access programs like the federal Pell Grants. And on paper, it looked like we had made it. On paper that I felt like we met our sort of contractual social agreement to the city of Green Bay and to the state of Wisconsin, and now our fierce Wisconsinites. And so, we achieved equality, I thought, right? And as I continued on in my own journey to learn more about public health, as my siblings and I went on to live our lives, what we started to find was that there was more than just having access to education and having access to resources. There was something deeper going on in the fabric of our communities. This is my brother's Facebook post. My oldest brother, Hong, that was born in Hong Kong. Wifey had water break during the older kids' Christmas concert. Oh my goodness, it was madness. Now at the hospital 5 weeks earlier than expected. So here, my brother was with his wife expecting their 3rd child, and little Ethan came earlier than expected. And this was terrifying to them and terrifying to us. And we didn't know why it was happening. My brother and his wife had followed all the rules, taken all their prenatal vitamins, gone to all their prenatal visits. They had a stable home. They were doing all they could. And as I dug into it in my own learning about public health, was that even though folks of color in our state, even though they might follow all the rules, that disproportionately on a population level, we see our babies born too soon and too small, right? And so that means a whole lot for our trajectories as individuals and as families. And so I dug deeper into this concept of equality and equity. And what I started to learn as I dug deeper is that equality and equity, while both concepts of fairness, equality is really about giving everyone the same things. And equity is making sure everyone has the opportunities and resources that fit their stories and their journeys and their needs and their assets. Which means we might give them different things, which means we might structure policies and systems differently in order to meet their needs to ensure thriving, but still that's a concept of fairness. Whereas equality holds us back because it holds us into this framework of sameness, which doesn't work for all of our communities when we think about a program delivery and policy implementation standpoint. So I felt like this image really captures well how we think about how we structure our community resources to ensure that all communities can thrive. And as you can see from this image, it doesn't mean that some communities thrive less because you're giving them different things. It just means you're really being strategic about those resources to assure folks have all they need. One of the metaphors that one of my partners really likes to use is that equality is like giving everyone the same pair of shoes, and equity is assuring that everyone has a pair of shoes that fit. For those of you that are runners, you know that those shoes are an important part of your running journey. And if you had the wrong size or the wrong set of supports in those shoes, your run or your jog wouldn't meet your needs, right? So this is really about how we assure folks have all those right resources to fit their needs so that they can thrive and be well and make the best choices to obtain health and thriving for their families. And a part of that process is not just what we do, but how we do it, right? So a part of what we study over at the Population Health Institute is not just the right policies, but how do we assure everyone has a say-so in the way decisions are made that affect their lives, that we know that it's really important that folks feel connected to the decision-making in their communities. And that's really important for policies to be designed and implemented to meet their needs. So equity, again, is not just about what we do, but also how we as communities ensure the conditions that support full participation of all people and families to co-create opportunities and have the fullest choices to be healthy, thrive, and live well from generation to generation. I will be making the slides available afterwards, so folks don't need to rush to take notes. You'll have those as a resource. And I'll share, one of the concepts that really get at this full participation is civic participation. We know as community leaders, our communities are more enriched when folks show up to our Board of Health meetings, our town hall meetings, and give their opinions and are vested in the ways those policies shake out. So this, I'll be transparent, is a stage picture. These are some of my nieces and nephews, and I asked my brother to get a picture of them as they were being civically engaged. So this is them in a staged voting picture. And they've been great inspirations to me as I continue to think about how we do this work. So I'm gonna have these slides again at the end, but wanting to set the stage for these definitions of equity, these stories that make up the fabric of our lives as community members of how folks came to Wisconsin. We all have a story as we look back into our generational history of how our families came here and how that deeply connects to our well-being and our health. As we convened statewide leaders in 2017, we said we need to have conversations, and we need to lift up the fact that racism, and structural racism in particular, is a public health crisis, is something that is about our populations as a whole, and it impacts our wellness. I'm going to dig a little bit into the definitions of racism in a second, but I just want to sort of zero in on this red bolded statement that racism, the reason why we care, one of the main reasons, is because it saps our assets, right? It saps our strengths as a whole community and wastes our collective human resources, right? As community leaders, putting at the forefront our capacity to harness human capacity and human resources, human passions, are our greatest assets as leaders to really invest and create innovative solutions for our most challenging issues. And there's a lot of reasons why the nature of our racial inequities look the way they do in Wisconsin. And the reason why these really impact all corners of our state is that our state is built, unfortunately, on a foundation of fear and leveraging racial divides in order to concentrate resources and power for just a few of us. And these are a couple of dot points. I try to keep the resources less on the academic side and a little bit more pragmatic. So those are the resources you'll find at the bottom of the slide. But we know that our state's current segregation and overall low racial diversity has been purposeful. That's been the makeup of our state. Milwaukee continues to be the most racially segregated city in the country. And as we look at evidence from across our nation and across the globe, we know that segregation, particularly by race, has detrimental effects to how our communities shape connectivity and belonging. And so this is a huge point of focus, right, for our state. And you heard from leaders in Milwaukee that really want to combat the situation in Milwaukee County. And this is true because of histories of redlining, where banks and mortgage companies literally used red coloring on maps to say where people of color, particularly Black Americans, Black Wisconsinites, could and could not live, and really zoned these places. And the places that were redlined were the worst places to live, were the places where there were environmental dumping sites, places near railroad tracks, places near coal plants. So folks were literally redlined into the places where they would have the least access to healthy environments. And zoning and racially restrictive covenants, rules that defined where and how we lived, really concentrated this type of segregation and this type of exposure to things that we know create poor health. In Black Milwaukee, a book that was published in 1985, really dig into how we further leverage policies as a state to bar Black Wisconsinites from holding public office, thereby limiting their ability to have a say-so in their neighborhoods and communities, and excluded them from military service and state militia. We also have a history of sundown towns, right? Rules that decided that not only kept people out, but moved people out. So from 1890 to 1930, Wisconsin counties with no African residents doubled, right? So that means African Americans that lived in counties were forced out due to these practices of these sundown towns that intimidated folks openly, discriminated openly around jobs, and refused to sell African Americans land. There was a practice too of folks and police officers meeting African Americans at train stations and pushing them to move on. So this is not a surprise that our state overall racial diversity is low, even though we were a destination site for manufacturing and jobs, that we really kept people out, not the kind of history that we are proud of in a state like Wisconsin that welcomed families like mine, leading the country in welcoming families like mine a few years later. So as we hold some of those practices, those concrete practices of states, wanting to get into a little bit of definition here, what is racism? And we're not just talking about the bigotry that's sometimes often experienced between two people, but we're really orienting around racism as an organized social system that's based on dominant groups, right? And also then creates inferior groups that then translates into how we devalue, disempower, and create different ways of allocating resources to some folks systematically. So this systematically structures opportunities for some and removes opportunities for others. And structural racism exists because there's multiple systems at play. This is not the education, just the education system or just the housing system or just our labor system, but it permeates across all of our systems that really we rely on to thrive and be well. And it's adaptive over time. That what I just shared around redlining, zoning, racial covenants, sundown towns, and there's a whole host of other examples. These have adapted over time to keep up with what's quote unquote more acceptable ways of structuring opportunities for some and not for others. And this relates to health because all these factors shape our capacity to be well. We don't think of health just as our physical well-being, but also as our social and mental well-being. And these are old definitions from the World Health Organization. And as we think of health and health disparities are differences in health by population groups. And we've introduced the language of inequities about 15 years ago as a field because disparities on their own didn't help us understand how to tackle them, right? That disparities on their own didn't tell a story about the chain of events that cause it, making it pretty difficult for public health leaders as well as governmental leaders to really understand how best to tackle these, what we've called now our inequities. So all inequities, health inequities, are of specific kind of disparities. So we consider disparity an umbrella term and inequities specific kinds of disparities. And health disparities, when they are inequities, are based on unfair, socially determined circumstances. For example, American Indians have higher rates of diabetes on a population level due to the disruption of their way of life and replacement of traditional foods with unhealthy commodity foods. These are policy decisions, so we can sort of tell an actionable story about how we might make change in this context. So health equity then is really about how we're allocating our resources and our opportunities to thrive and be well across not just physical health, but also social, economic, and mental well-being. And it requires an environment where everyone has a good chance to be healthy. And it really takes equity in order to assure our health equity then will be achieved. I wanted to offer a little bit more specific context about how this shows up in our state and how some of the earlier policy decisions around segregation have impacted the distribution of where Black, Indigenous, and people of color live in our state. In a public health context, we divide the state by 5 different regions. So that's how you'll find this data. And you'll see the proportion of folks that live across our state. We do have folks of color living in all counties in our state that we have. So this is indeed a statewide issue, but certainly we find that our most diverse communities live in our the southern portion of our state and disproportionate more urban areas. And this shows population by percent, similar to the previous graphic. And you'll see here by percentage the distribution by ethnicity of folks across our state. And again, we have Hispanic and Latinx community members that live all across our state, with some concentrations of folks in both our southeastern region and our southern region. And as we think about, again, a different image to understand where Black, Indigenous, and communities of color live by county, this is a map that shows population density by race and ethnicity of our state. I think particularly notable, and as a part of our own history, is that we have American Indian colleagues spread throughout our state with our rich network of both federally recognized and unrecognized tribes. And I'd be remiss if I didn't reference COVID-19 in the context of our conversation. We know that this pandemic has exacerbated a lot of existing racial inequities in our state. So wanted to offer that look. Much of our data across any health issue often falls along these race and ethnicity lines. But we know so far, and our pandemic isn't over, that communities of color have experienced higher rates of COVID-19 cases, hospitalizations, and deaths since the pandemic began. So when we compare to white Wisconsin residents, we so far find that Hispanic or Latinx residents have 1.7 times greater case rates. Black residents have 2.1 times higher hospitalization rates, and American Indian residents have 1.4 times greater death rates. So here, this image you see by percent population, the sort of percentage of those ethnic or racial groups represented by population. And here the purple circle is biggest for our white population because our white population makes up our largest percentage. And then the bubbles sort of adjust based on the data. And in the next column, you see percentage of all COVID-19 cases. And if the bubble is bigger in the second column than the first column, that represents disproportionate burden, right? So you can see here, this one shows in particular, and then in the third column, you see that bubble adjusted for that disproportionate burden. And at the top of this chart, you find as the text says, Hispanic and Latinx populations having the biggest case burden. And I think when we see this information in the media, we often think, well, it's because individual behaviors, right? And what we know is that our social environmental contexts really are huge drivers at why this data is true. And I can dig into that in just a second. This is an image for our hospitalization rates. And as the text says at the top, Black Wisconsinites have been disproportionately burdened by our hospitalization rates. So they've flipped to the top of the chart. And then on this one is our disproportionate burden around death rates. And that you see here, American Indian residents in Wisconsin go to the top of the chart because by and large, the American Indian community has been disproportionately hit hardest by our death rates. And on a population health level, especially for governmental leaders, these rates go far beyond the particular groups that they impact, right? They have far ripple effects, not just on these communities directly, which is vast, but if we are thinking about structuring social, economic, and healthcare resources to meet the needs of our communities, we all bear the burden of these disproportionate or preventable burdens by specific communities. I'm going to cruise through these slides pretty quickly, but all to show that in public health, we really orient around work to decrease mortality and morbidity. And we've done a lot of work to think about, well, what are the things that really prevent morbidity and mortality, because we experience the most cost, not just in dollars, but in grief and burden, social burden on communities when we wait to just decrease mortality when we get to the hospital, right? So this shows us our ability to go upstream, if you will, in terms of prevention. And what we know from evidence is that the further upstream we go, these investments have long-term ripple effects, both in dollars and social impacts, if we can prevent disease from even starting. So on the far right, you see our downstream areas, which include mortality and morbidity. And the way we address mortality and morbidity most directly is within the hospital setting and by preventing disease and injury. But if we go upstream in public health, listen to our evidence of where our best investments are for the long term, we start to see that investments in shaping healthy living conditions really go a long way to decrease risk and disease and injury and death for the most community members. What we find, though, is that in public health, we've sort of been stuck in this living conditions area, which we call social determinants of health. And we have opportunity to go even further upstream to really think about, as you all are doing in this webinar series, how we embed these concepts of racial equity, diversity, and inclusion into our institutions, how we make decisions, where we make decisions, and really unpack the biases that we have that make it difficult for us to use that equity approach in our policy making. So going further upstream represents an equity framework, really closing gaps in these root causes, alongside of complementing our work to close gaps in downstream outcomes. Another way to represent this, and hopefully this feels familiar, is through our population health model, through the county health rankings, our national program. And again, this program really has created buckets of things that shape health to help us understand how we can go upstream through addressing health factors in policies and programs. And what we continue to see over decades time of this work is that these social determinants of health, those social and economic factors, make a huge difference, again, at preventing disease and allowing for folks to really make those healthy behavioral decisions, because folks are making health decisions based on the opportunities they have, right? And all of these factors also shape good quality clinical care. And so what does race have to do with health? We know, as I mentioned earlier, that structural racism is a lens that shapes how we make decisions across all sectors. There's no sort of sector that we haven't observed a racial lens at play. And so these are really big opportunities for local leaders, state leaders, and federal leaders to sort of unpack and remove or mitigate the racial bias that operates within the context of each of our sectors in order to construct healthier communities for all folks. I'm going to skip over this. Well, I'll do this one quickly. Again, these are the forms of racism. And while we care deeply about the racism that occurs between individuals, interpersonal racism, I'm really focused here today on institutional and structural practice as key opportunities, particularly for county leaders. And I want to sort of note here that racism, structural racism, manifests as poor health outcomes in a lot of different ways. There's lots of research happening to understand how, if you will, racialized systems get under our skin. And one of our most robust areas of research is through chronic toxic stress, our cortisol levels. So those that are experiencing racism day to day, interpersonally and through systems and structures, are experiencing stress every time they interact with those individuals or systems, creating a multiplier effect across stress. And that stress really embodies itself under our skin. One of the metaphors that came up for me actually as I drove in a snowstorm, I was driving pre-pandemic. We spent a lot of time on the road getting across the state. And that meant we also spent time in snowstorms. And in one particular harried snowstorm, I was driving back to Madison. And for anyone that has ever driven in a snowstorm for a prolonged period of time on our highways, you remember that sort of white knuckle driving, that heightened vigilance that you're watching around you. And you can't just be concerned with what you do as a driver, right? That you need to be concerned about how everyone is driving around you, because the hazards of skidding out, sliding, things that might come before you, all represent obstacles that you can't control, but you need to navigate. And that's sort of the feeling of chronic toxic stress, that tightness in your chest, the tightness in your muscles. And if you are that way for a long period of time, imagining driving in a snowstorm every day, what that does to your body and your systems. And that's why over time, if folks are experiencing this kind of stress, it means they get sick easier and faster. And when they get sick, they stay sick longer. And you might know this too, if you're ever stressed out at work, you might get a cold. And if you get a cold, the impacts of that cold are worse. And for many of our communities, especially our communities of color, the snowstorm doesn't stop, right? And they're driving on highways that have more potholes than you do, right? Because of the systems that are compounded over time. Right. And that's not what we want for any of our community members. But we know that the impacts of driving in a snowstorm that never ends has harmful impacts all across the board, but especially for our physical health. And what's more challenging is this persists across generations. If we do not address these issues in a generation, we pass them down literally because of the way it impacts our, some jargon, our reproductive potential, both in men and women, as we pass down those stressors into our babies. And that's why for communities like mine, our babies are disproportionately born too soon and too small because of these impacts of chronic toxic stress. And that has ripple effects across generations. And that is why historical trauma from forced removal from land and enslavement continue to persist, because as nations, we have not undone the impacts of those historical traumas. And so we have lots of opportunities, especially as community, county leaders, local leaders, to mitigate and undo the impacts of these systems all across the board. This image actually comes from NACO, the National Association of Counties. And we've learned a lot from the resources coming out of NACO, that in the roots, there are opportunities for us to restructure systems and really hold ourselves accountable to assuring our systems work for all community members. We can address negative community assets such as disinvestment and powerlessness, and really bolster positive community assets that you see in the tree trunk, supporting participation and leadership, social networks, social support, to really address those impacts in the branches and leaves in our healthcare systems. But we need to work all across the spectrum, from the roots to the soil that provides nutrients to the tree trunk, in order to really get the most out of our social and economic investments in communities. Targeted universalism is a way we can think about really structuring our policies from an equity perspective, to take universal goals and then understand where groups have differential access to those goals, and really structure our implementation to meet that differential access. Throughout our processes, think about not just the what, which is those root causes and social determinants, but also the with who, right? That I think about our engagement with community members and other agencies as sort of wide and deep engagement. wide across sectors, but deep in our communities, particularly those that have been most impacted by inequities, and through our how, that we have a lot of opportunities to structure, to address how our structures and processes ensure those impacted by inequity are our key partners in shaping solutions, so that we hear and can sort of respond to those experiences by the way we allocate resources and implement policy. And this is really what we know to be true, is that we all do better when we all do better. When we use a racial equity lens, and we've done this training all over the state, sometimes we don't say racial equity at all, and we can still get at this. We think it's important to say racial equity because of the way that that has showed up in particular for many community members. But really, what we found when we talk to community leaders across the state is that this is good public policy, right? That good public policy should ensure families of all shapes and sizes can thrive and be well, should privilege our local economies and thriving economies, should assure that we can age in place and have livable communities. Good public policy should address poverty, particularly childhood poverty. Good public policy should address accessibility for those living with disabilities in our communities, should be good for women, right? Good public policy should support our lesbian, gay, and transgender community members. Good public policy should support our youth and our mental health and a healthy planet, right? And what we found is when we put racial equity in that space of decision making, it helps us do all these things, that it's good for all of our community members when we use this lens. And we lead with public health, not because, and we certainly don't need to, but by definition, public health is what we as a society do collectively to assure the conditions for all people to be healthy. So whether or not you do it in a public health context, that's really not my primary concern, but it's really about how all parts of a community, all parts of sectors are working hand in hand and in tandem, because none of us can do it alone. We need all parts and all assets of our communities to tackle some of these wicked challenges. Here I've landed again our racism as a public health crisis declaration. You can find this on our website. Our hope is that we can help get the word out and provide resources to folks working on racial equity issues across a spectrum. You'll see the declaration itself, which also gives links to some of the citations that we use, and also lists actions for either organizations or individuals to sign on and commit to in order to advance this work. Each of these actions also have action toolkits that can support the work across the spectrum. And we do also support a community of practice for anyone interested in advancing this work. You're welcome to reach out to me, or if you sign up for the declaration, you'll also be included in our mailing list for the community of practice. These are the individual actions. And I have a little more than 10 minutes here to answer any questions. I know I've seen things pop up so I'll start with the Q&A first. And so I'm seeing from Amy, thank you for the clarity around equity versus equality. It seems as though it could take people, particularly those in privilege, perhaps longer to agree with these notions. It's a learning, unlearning process to move toward buying in to the importance of equality and then move towards buying into equity. I see that perhaps it's going to take many more resources to achieve equity than it would to achieve equality. Equity ultimately may be harder to accept because now you're saying even more resources would need to be expended in unequal ways. Is that right? So, Amy, that's a really great point and a really great question. I think equity is also about how we are strategic in our resource allocation. That in some cases, we've talked about allocating resources from a public policy context when folks don't need it. And in fact, we do this all the time, right? We structure our policies and systems all the time to orient towards those with the most need or particular identities. I think packages for veterans are a really good example of how that's not a resource available to everyone. That's a resource available to those with a very specific identity and a particular set of needs. So there's lots of examples of how we're doing this already. Medicare is another really good example of us structuring a system of policies and resources for a very specific part of our community. So I think a part of it is the framing, and also thinking about the community impacts, right? I don't have any kids, but I am happy to invest in our public education system because I know that that benefits me and my community long term. So I think orienting around collective community investments that might create differences in our investments, but lifting up examples of where we do that can help, I think, support buy-in. From Jeff, many people in local government will not acknowledge systemic racism exists. How do we change that value in a person or organization to move forward? Jeff, I think that's right. I think there's a lot of people who won't acknowledge systemic racism, and sometimes that might not be your goal. You know, I think as community leaders, really identifying where you do need to invest those resources to convince people is important. And as I mentioned, a lot of the tenets of using a racial equity lens is also about sound public policy making, right? So I think thinking about where those win-wins are for the overall collective community is just as important as getting someone to acknowledge systemic racism. You know, I think for me in my own journey, I don't always try to convince every individual that I interact with that racism is real. And what we know is that there's a lot of negative outcomes in our community. And what I know to be true of most people I interact with, they want the best for their families, right? They want the best opportunities. And if we can orient around where there are win-wins for us to create the best opportunity for our families, there's a great deal of bridge building potential in that space. Amanda, can you tease apart terms like race and ethnicity? I will drop in resources. Our State Department of Health Services has really offered really lovely definitions of race and ethnicity. So I can make sure that those resources are linked in my slides and share them, and won't try to do that off the cuff today. Amanda, again, do you have resources about financial costs of racism? Yes, there's lots of research on the economic cost of racism. And I think what we know is also important is when you sort of quantify our social and mental health costs due to racism, it becomes much bigger. So there's lots of questions that you can ask related to how you're defining costs, but there's lots of evidence around the cost and impacts of racism. Why is voter ID an inequity issue? So voting has become an issue of participation. It is an issue of participation. And what we know is policies have been passed to make it difficult for some community members to vote, and requiring specific kinds of IDs for voting are disproportionately making it more difficult for communities of color to have access to voting. And I can share more resources on that as well after the webinar, that there's, especially over the past year, a lot of research around targeting voting and making it hard for some populations to vote as a pretty big racial inequity issue. Do you have suggestions or examples of meaningful policies that address racism? I think there's many examples in terms of thinking about how we structure our education system, our housing system, our labor, how we structure jobs. So there's many examples, and one resource I will share is the Government Alliance on Racial Equity, or GARE, and I can also share resources on GARE as well. We will pull these questions, I think, afterwards, so I can make sure we pull enough resources across these questions, but can definitely share resources on policy examples. From Troy, the Race to Equity report completed in Dane County in 2016 has been criticized recently in the Cap Times as not addressing the issues identified in the report. why has Dane County and Madison struggled to improve equity in the community? I think that's a great critique, and it's certainly something we talk about as in my role as a Board of Health member in Dane County. I think there continues to be racial inequities that are pervasive in how we deliver care and resources and how we assure individuals in communities have access to participating and making decisions. And many of the decisions are not popular, right? So I think there's lots of reasons why we have not tackled these issues in Dane County. And I think there's on the flip side, some of our opportunities are in the level of engagement that that Race to Equity report contributed to building momentum around to change some of our funding. And some of these things we might not see overnight, which if you are going further upstream in the types of policies and systems you're trying to change, those immediate outcomes are rarely felt. So both investing upstream and coming up with a way to measure short and long-term success is a key part of those efforts. And there are some ways that we're seeing good, promising changes in some of those process metrics that are going to take a long time. But I would agree we have a ton of work to do in Dane County, and really excited to look at neighboring places like Milwaukee County and some of their strong statements that are really not just statements, but also using racial equity checklists in their policymaking in their agencies that can serve as models for other counties, including Dane County. Can you recommend resource areas that would help a county to evaluate how they are doing and where best to start working? Yes, on our website, you can find resources on how to assess where you are as a county and as a community. GARE, again, the Government Alliance on Racial Equity, has suggestions for assessments as well. And this is also something we're happy to provide consults around to help you get started. And my email is on this slide here. From Lisa, how do you help people to see that one may have racism within us without recognizing it? Too often people say, I don't see color, I see the person, without really turning the mirror on themselves. Lisa, I think that's a huge challenge. And where I start with is that we all breathe this air, right? Racism is not about the shark in the water, but racism is the ocean, right? In which we swim. So we are all impacted by racism, and we all hold biases. There's no one in the state or in the country that can say they are completely immune to it. So beginning to unpack in yourself how that shows up can help model for others and help you have honest conversations. And again, thinking about where you want to invest your energy is important. Sometimes it's not about helping someone recognize racism immediately, but talking about the systems and structural impacts and then bringing them along longer term. One of the things that I've learned from our community organizing partners is that sometimes it's not about thinking your way into a new way of doing, but acting your way into a new way of thinking. And sometimes we got to start with the actions first. And that might mean that some folks are uncomfortable for a while, but then once they start seeing the impacts, it helps to change the way they think, right? We've seen the same around bike lanes. We've seen the same around smoking. We've seen the same thing around seatbelts, that there was when those policies were first passed, people were really upset and didn't want to take part. We're seeing the same thing now around masking. And when you look in hindsight and see the positive impacts from those policies, generations to come begin to adjust their way of thinking. So it's that balance, right, of especially as community leaders to strike around how many people you need to convince that racism is real before you take action. Troy put in a link to share. Really appreciate that and can dig into that further. And I know I've got 1 minute left here, so I'm gonna pause on questions, but again, I think we will be able to download all of the questions in the chat, and we can pull together some resources to share after the webinar. But I'll hand it over to you, Sarah, to wrap us up.
All right. Thank you so much, Paula, for sharing that wonderful information with us. We will be placing all of the recording, the PowerPoint presentation. I know Paula referenced some additional materials, some additional links. We will be putting all of those on our website under events and past event materials. So with that, we look forward to seeing all of you next Monday when we discuss getting started, moving from words to actions. But for now, thank you once again, Paula, for sharing your slides and your knowledge with us today. And again, thanks for joining us, and we hope you all have a great week.